future of healthcare has arrived. Artificial intelligence and machine learning are transforming the practice of medicine and improving patient outcomes. This is Smarter Healthcare with AI. Conversations with Dr. Hassan Tetteh as he shares insights into the healthcare of tomorrow and how we can help create it today.
My guest is Dr. Stephen Charlap, founder and CEO of SOAP Health, a digital healthcare startup applying AI-driven virtual health assistants to improve healthcare data collection and analysis. With over 30 years in healthcare, Dr. Charlap's diverse career includes roles as a surgeon, biotechnology executive, founder, and he holds an MD from NYU and an MBA from Harvard. He's a serial medical entrepreneur driven by a passion for preventive medicine and improving patient outcomes. Dr. Charlap, welcome to the podcast.
Thank you, Dr. Tetteh, but feel free to call me Steve.
Okay, very good. So I think one of the very first questions that will be very illuminating for everyone is, what inspired you to create SOAP Health, and what is SOAP Health?
By the way, I've been in healthcare now 40 years, graduated medical school in 84, giving away part of my age. Unfortunately, what inspired me to create SOAP is not a happy story. About 10 years ago, my older brother, a practicing cardiologist, lost his life to a misdiagnosis. My brother was a great doctor, loved by his patients, but an even better brother. He was the one I shared a room with. He was the one that told me bedtime stories, bought me birthday presents, let me put my head on his lap during long, hot family car trips. Even though he was uncomfortable, he let his little brother get comfortable. He was really an amazing human being, and his passing was both painful and unfortunate because it could have been prevented. I was working on my second startup at the time, a primary prevention medical center, and I closed it a month after his passing and went back to school at Stanford, was a fellow for a year, and then a second year was involved in a research project that looked at whether Stanford doctors know how to do proper risk assessments, which is a major contributor to my brother's death. We published that they did not. And then the third year, Stanford gave me a grant, and I built an early prototype, one of the early prototypes, actually the second version. And then I left for Harvard for 2 years, and Harvard funded a small pilot. And then I founded SOAP about 5 years ago.
Very, very cool. And what is the SOAP platform? Knowing that's Genesis, knowing that it came from a place, obviously, of pain and a bit of tumult, and, as you mentioned, identifying a problem that is seeking a solution. How does SOAP work?
Right. So I hopefully don't sound immodest when I say it is the most significant product of this quarter century, and I hope it will be the most significant product of the half century. SOAP was built to address a number of fundamental flaws in primary care, and we also now address internal medicine subspecialties, gynecology, family medicine, pediatrics, etc. The fundamental issues are that doctors no longer have the luxury of spending as much time with their patients as they wish. They also suffer from knowledge gaps as there's ever-expanding medical knowledge. It's well established that they suffer from decision fatigue, which means as the day goes on, they're not as conscientious in the afternoon as they are in the morning. There are many distractions. There are the wrong financial incentives in healthcare. We have no real incentives to prevent or earlier detect disease. And of course, there are issues between humans with miscommunication, human error. A study that showed that more than 50% of Americans lie to their doctors about things that might embarrass them. Burnout, the list goes on. What does that mean? Well, here in the United States, we know, according to the National Association of Community Healthcare Centers, over 100 million Americans don't have access to primary care. Another 60 million Americans have high deductible plans, so primary care is not truly affordable. So one can arguably state that half of the American population does not have access to affordable, quality primary care. And globally, that number is about 4.5 billion out of 8 billion people don't have access to primary care. So this is a big problem. And what's the consequence of this problem? Here in the U.S., according to a Johns Hopkins study, nearly 400,000 people a year die from misdiagnosis. Another 400,000 become permanently disabled. And the National Academy of Medicine now predicts that everyone will experience a misdiagnosis. And on top of that, according to the AMA, 65% of doctors are sued by age 55, and for every doctor over the age of 40, there's a malpractice suit. So everybody is suffering.
I'm saying yes through all of your lists of the ailments that afflict our system, because I've experienced almost all of them on both sides of the equation, being a patient, being a father, being a husband, dealing with family members that have been subject to the system, and of course, experiencing all the things you aforementioned happen to providers as well. So
what is SOAP?
Yeah.
Yeah. So let me start with, by September, we will complete the world's first AI-powered primary care provider.
Say that again so that the audience can fully appreciate and let that sink in.
The world's first AI-powered primary care provider. It will do everything a primary care provider does other than examine you, which is still a critical function of medicine, but it will do everything that a telemedicine provider can do for you. What we've built already is 3 of the world's most significant applications. The first one is called the Perfect Medical Interviewer. It is patented, patent issued. It has been clinically validated at Stanford and elsewhere. It is the world's most effective methodology to collect information from a patient. When you collect information from a patient, there are 3 elements that are critical: truthfulness, accuracy, and completeness. Our digital human, animated character, soon to be offered in choices, so different ethnicities, different genders, different ages, is able to carry on 100% voice-based conversation with a patient. It collects more truthful information because there's a mountain of science that shows when humans interact with a digital human, they don't feel the need to maintain a good impression or manage their reputations, and they don't fear being judged. And so the brain lights up differently, and they tend to answer more truthfully and more verbosely than they would to a human being. So we get more truthful responses than the typical doctor or any type of form. 2, we ensure accuracy by 3 methodologies. 1, we use intuitive imagery to let the user understand the nature of the question. 2, we reflect answers back to the user. And 3, the question can be heard on a voice level or on a visual level, which means that for people who respond better by voice or people who respond better than by visual, they can choose how they're going to interact with the application. So we improve accuracy. We improve comprehensiveness by 1, forsaking speed over accuracy. So this isn't a 5 to 7 minute intake. The first time you're interviewed by Jeannie, the digital human, it is a 25 plus minute interview because she's going to ask everything that's important to know about you to have a holistic view of who you are. And she's going to combine a systematic approach to asking questions with an open-ended approach. Now, what does that mean? We're taught in medical school, ask patients when they come in, what brings you here today? Or what can I do for you? Kind of an open-ended, asking the patient to volunteer information. Believe it or not, that very good studies showed that approach, which is taught in medical school and used universally, misses up to 70% of major symptomology. Up to 70%. And so why is it used? Well, it does have some benefits in that it does allow some free thinking by the patient and expressing themselves in their own words. So we combine asking patients questions open-ended, including their perspective on their symptoms, with a systematic approach to symptom exhaustion, including asking questions about subtle symptoms that may not rise to the level of a patient typically sharing them, in order to improve catching early cancers and heart disease, which happen to be the two most commonly misdiagnosed ailments in the U.S. Once we capture all that information, we feed it into RiskView, which is patent pending. It is the first risk and symptom assessment program built on the back of published guidelines with over 500 hard-coded risk assessments integrated with a large language model to feed all the data we collect and generate a differential diagnosis, which has already been proven to be more accurate than the Mayo Clinic's reported rates. And then it generates additional questions to the patient to narrow down the diagnosis, and then recommends testing to further narrow down the diagnosis, and then processes the test results to further narrow down the differential diagnosis. RiskView is the world's most powerful risk and symptom assessment tool. And then finally, it pushes the data into a new modality for doctors to be able to easily review, edit, finalize, and then pushes discrete data into discrete data fields, today already in Athena Health. We just signed up over 30 medical practices that use Athena Health for our application. We have contracts with the National Cancer Institute and another large governmental agency outside the U.S., but that information is still embargoed. A huge contract working with a major healthcare medical institution to improve early cancer detection. Again, the product of this quarter century is now in market.
Congratulations. I want to expand on the things that you just outlined, just to again give our audience perspective of what you just outlined, because when you see it in demonstration, as I've had the privilege of doing and appreciating, it's amazing. It's fascinating. And it is, as you mentioned, and as you say, truly revolutionary and game-changing in terms of how it could fundamentally upend what has now been done for decades with not so great results, as you outlined in the very beginning. So when you talk about the perfect medical interviewer, I want to just go back to my medical school days. And as you mentioned, we're asked to, invariably during the first rotation in clinical to say, what brings you in today? That's like the open-ended question, as you mentioned, is taught all around, the country in medical schools. I want to go a little bit further, though, because I do remember something that always stuck with me, because over the couple decades that I've been practicing as a cardiac surgeon, one of my internal medicine professors, who ultimately became the chair of medicine at my alma mater, would always tell us as medical students in our rotations that if you listen to the patient, truly listen to the patient, they will tell you the diagnosis. And, that has been proven to be so true. But you mentioned many of the barriers that prevent us as providers for having the ability, the opportunity, and the system to truly listen to the patient, right? Because we're time pressed. We are incentivized not to listen to the patient entirely and take in an inventory of everything that may be going on with them, but just to focus on the chief complaint, which you just identified as probably not the real reason the patient's even there. And when we don't have that luxury to listen to the patient and truly understand what's happening, we holistically miss everything. So when you talk about the perfect medical interviewer and this platform being able to take this comprehensive inventory you are absolutely doing exactly what Dr. Friedman espouses we all do, which was listen to the patient. And in doing so, you're able to synthesize this differential diagnosis that you are now able to present in risk view, and then, give the providers and the healthcare team a roadmap of what they need to do to narrow the diagnosis down and hopefully articulate a plan for the patient. So in doing all of these things and knowing what the great potential is, how do you expand this to the masses? That may be the $1 million question, literally and figuratively.
The first rule of medicine is first do no harm. We are still, even as we are releasing it, rigorously testing it for widespread applicability. Let me be transparent. 2 weeks ago, a patient complained. Why did they complain? Because there was a question that asked them whether a particular disease was the cause of death of their relative. And the image associated with death was a tombstone. The patient was triggered by the tombstone and complained. And so we replaced the tombstone with an empty bench sitting on a hilltop with a setting sun to reflect death.
Person is no longer there. Yeah.
Right. So there are subtle challenges sometimes when you release something that people are not used to, and you need to make sure that it doesn't offend and is highly accommodating and engaging. So we are still rigorously testing. Like I said, we have a National Cancer Institute contract with 400 patients to demonstrate high acceptability, as well as that it will save, and we've proven this in other pilots, but this will be formal and published, that we can save up to 12 minutes per patient encounter. Now let's stop and think about what that means. Free up 12 minutes from an encounter. If a doctor sees 25 patients in a day, that's 300 minutes. That is 5 hours freed up. How they use that time may be to spend more time with their patients, talking about other things, getting to know them better. It may be reading more journal articles so they're more knowledgeable and up to date. It may be going home earlier so they're more relaxed and so they work under less time pressures and under less stress, contributing to less burnout. The application also actually catches things that doctors miss consistently. We have a case study of an 18-year-old Hispanic woman who came into a clinic complaining on and off of headaches for several days. Didn't give any reason for the cause of headaches other than some anxiety. Didn't share it with the nurse who did the triage. Didn't share it with the physician. At the end of the encounter, physician unaware of what might be causing the headache, wrote down and referred to a neurologist. He was then shared the information that was collected by Jeannie, unbeknownst to him. Jeannie, the patient, disclosed that she was being sexually abused, thereby changing the referral from neurologist to mental health counselor. She wasn't comfortable telling the healthcare professionals directly what was actually going on causing her headaches. Just a very, very poignant and unfortunate example of how a digital human can collect information more accurately and truthfully than a human. So the application has also demonstrated that it reduces no-shows, because when people become engaged with Jeannie, they want to follow through and find out, what did Jeannie discover? And so in a practice of 105 patients in rural Alabama, all 105 patients that engaged showed up for their appointment, reducing a 12 to 14% no-show rate to 0 for those patients. She obviously is going to reduce malpractice exposure. So for the universal scaling of such an application, because the first rule of medicine is first do no harm, we will continue to validate religiously here in the United States and in the UK as we continue to identify opportunities to scale. We've been approached by the United Arab Emirates. We've been approached by Brazil, Bangladesh, India, Germany. Many countries understand the value of what we've built, but we're not ready yet for full release until I am comfortable that one, Genie can speak every necessary language. The patient can choose what type of character they want to integrate with. Genie is getting close to 99% accuracy on diagnosis in the first place. So there is still work to be done, and it is being done religiously by our 40-plus person team.
Wow. Again, congratulations on what you have built and what you are continually testing and validating, because, that's exactly what you're doing here to make sure the platform and the experience is as close to perfect as possible when it comes to diagnosis and having the patient's sort of complaints be articulated into their diagnosis and problems. So you talked about some of the challenges that you have faced with scaling, and certainly testing and validating is necessary to achieve the level of comfort and the assurance that you want to make sure that as it rolls out and it scales, it will continue to have the fidelity that it has in the pilots that you currently have. When you think about shifting gears just slightly, when you think about how this tool can sort of impact the larger health ecosystem, what would be your hope or your vision as you see it?
Assuming that doctors remain in the loop, or some equivalent of somebody able to provide oversight over the AI and the application, I believe that an application like this becomes a major force multiplier. So one of the reasons why there are so many people who don't have access to primary care is because primary care providers are on short supply, and it's being exacerbated by the number of primary care providers who are either retired, resigned, finding alternative livelihood, or joining concierge practices. Okay? We need to give physicians or some equivalent the ability to see far more patients and to see them at a very high quality level. This is also the great equalizer. So I envision in the future that the role of physician is going to metamorphosize. And what that means is that the physician will be where the buck stops, where the technology will do all the basics of interviewing the patient, collecting physiological data, interpreting it, and getting a handle on what's going on, having a precision profile of the patient, and calling in the physician when that level of expertise is required. Okay? I don't believe that technology can stand on its own. It's not that AI isn't going to be smarter than doctors. It's going to be smarter than everybody. Okay? It's like Gary Kasparov said in the 1980s, AI was never going to beat a chess master. Well, 10 years later, AI was easily beating the chess masters, and today it's a no contest. So that's not the issue. The issue is that technology can fail. For example, my wife's Mercedes-Benz SUV several years ago was driving down the highway 1 o'clock in the morning and stopped dead, just stopped dead. The computer had failed, okay, putting her in a life-threatening situation, particularly if it had been earlier in the day where there was heavy traffic, it could have been fatal. Right? So we understand that technology requires some level of oversight. We will not let it completely autonomously operate on its own. But that said, it can allow a physician to see 10,000 patients versus 2,000 patients, which means that 5 times as many people could be cared for in a high-quality fashion than they are today. So the technology is just a tip of the iceberg of enabling far more quality care to be delivered to far more people, also in a highly affordable manner. Okay, in healthcare, and I'm sure you're going to agree with me, whoever develops absolute power seems to abuse that power. So there's a lot of people who say, well, insurance companies have taken away all the power from physicians and we should give physicians back all the power. Well, post-World War II, when physicians had all the power and so did the hospitals, they were overcharging. So the answer is not to give anybody power, all the power, including technology. Because if technology companies suddenly become more powerful and the source of all medical care, there is risk for abuse as well. So we do have to be very mindful of making sure that the implementation of this technology from a public health perspective remains highly affordable and accessible by all.
Absolutely. When you look at that vision of this accessibility, the affordability, and thinking about the almost inconceivable problem that we have, and what I mean by that is, 400,000 people dying from a medical error, 400,000 people harmed, right? You're talking about almost 1 million people. And truthfully, those numbers are probably not representative entirely because we know that you just don't know sometimes. People go home after a visit. We may never know what happens to them. And it could be, part of the either misdiagnosis or something else. So, let's just think about that number and addressing that huge amount of not only morbidity and mortality that is largely created through our healthcare system because of its inefficiencies, because of its ineffectiveness and the things that you outlined that are very well known and very well documented. Is primary care the only answer? In other words, is this the so-called silver bullet or the thing that can untie the Gordian knot? Or is it just part of a larger picture? Just so those of us listening can kind of appreciate how does SOAP and this type of technology fit in?
So there are a number of studies, and they're easy to dig up, that show that where there is absence of primary care, care becomes more emergency-oriented. Okay, people who show up in emergency rooms without access to primary care usually show up in a worse state, in a more advanced state, in a more costly state to treat, in a more life-threatening state, etc. So we've got to start somewhere at the basics. We as a society do not value preventive medicine. Okay? We don't even reward for early disease detection.
That's correct. We don't.
Okay? In fact, one could argue, if one wants to be perverse, that the $1 trillion+ that is incurred due to misdiagnosis would be adversely pulled from the pockets of the people benefiting from it, which are ultimately doctors, health systems, and payers. In other words, $1 trillion, which is roughly a quarter of our healthcare system, would disappear if medicine was perfectly delivered. But who would suffer? The providers, the payers, etc. So they don't have an incentive to lose $1 trillion worth of compensation. And so our system is fundamentally broken, not just in terms of the mechanics, but the financial incentives. People follow the money. Look, I always use the example in my first company, I was venture capital backed, and my bonus plan was tied to revenue. So guess what I didn't care about? Profits. I only cared about revenue. Even though I was a major shareholder and profits are ultimately what drives value, I was short-term focused on maximizing my take-home pay because I was a poor kid from Brooklyn. And so all I wanted to do is grow the revenue. And guess what? The revenue grew every year for 19 years, but the bottom line was like unpredictable all over the place because it wasn't impacting my wallet immediately. We need to align the right incentives with fair compensation, with managing expectations of people going into medical school, of what they can expect to coming out. We need to emphasize the importance of prevention and early detection. But let me just talk about prevention for a moment because it's almost misused. 1 out of 5 smokers develops lung cancer. 4 out of 5 lung cancers develop in smokers. The 1 out of 5 people who develop lung cancer are identifiable. Those are the ones where we should focus our most attention on trying to get them to stop smoking. Some people are at significant increased risk for diabetes and prediabetes. They're identifiable. That's where we should focus our attention in trying to retard the progression to prediabetes and diabetes. This is personal. I'm a diabetic type 2. I am not overweight, but I do have a family history on both sides of diabetes. Okay? So I'm the person that the minute I stepped into prediabetes, major attention should have been paid to stopping me from progressing. Now, with medications, I'm back in the prediabetes range, but the point of the matter is prevention should be targeted, because when people talk about prevention doesn't always pay off, they're right. If we waste diabetes education on someone who's never going to be diabetes, that's just a waste of money. So we need to target prevention, and in order to do that, we need to understand our population better. Now, the All of Us Research Project is trying to do that to a certain extent, but they have a terrible intake tool. Terrible. Awful. I tried to fill it out. It was so bad I gave up. The person running the program at Scripps told me she gave up because it was so bad, and she runs the program. My point of the matter is there are so many things we can fix. Technology is not the answer in and of itself. It is part of a toolkit of solutions. But everything starts with understanding the problem. There's too many people trying to have the tail wag the dog by simply throwing AI or whatever other nomenclature you want to use, or new technology or fab technology at the problem without fundamentally understanding the nature and cause and etiology of the problem.
Well said. Your plan involves, number 1, learning more about our population. Number 2, improving early and affordable access to care. And 3, encouraging healthy individuals to engage with the healthcare system proactively. Indeed, this approach could address the morbidity and mortality issues we've discussed. Okay, we'll have to pause here, but next time with Dr. Stephen Charlap, the founder of SOAP Health, we'll delve deeper into the future of healthcare and medical education, and Dr. Charlap will share some advice for healthcare entrepreneurs.
There has to be a reason why you do things. You just don't do it because you want to make more money. People are not going to follow that lead. Give them indications. Give them good science. Give them evidence. And people will do the right thing most of the time. Not all the time, but most of the time. Okay? But if you don't give them frameworks and guidelines and evidence and science, then you're basically shooting your business models in the foot, and you're going to cripple yourself going along.
This has been Smarter Healthcare with AI. If you'd like to find out how to bridge the gap between medical experts and tech innovators and discover how AI can make us healthier and more human, go to Tetteh.com. Smarter Healthcare with AI with Dr. Hassan Tetteh is a production of Forbes Books.